This is a special Grand Rounds presentation. It's a part of a visiting scholar series here at CHIO and supported by CHIO-RI and funded by the PSI Foundation. And I'm going to hand it over to Jason Berman, who's going to talk a little bit about the series, and then Roger will introduce our guest speaker. So Jason.
Thanks very much, Kieran, and good morning, everyone. Really delighted to welcome Dr. Lavis to this special PSI sponsored Grand Rounds. I did have some slides here, but I'm having trouble bringing them up. So I'll just speak about PSI, which I know many in the audience are familiar with. This is an organization that was established by physicians as a foundation to fund physician-led research in Ontario, and has been, the PSI program at CHIO has been very successful at bringing in guest speakers like Dr. Lavis to share their backgrounds and experience with us and help build capacity at CHIO in a variety of different areas. I'll remind the trainees in the audience that one of the programs PSI offers is the resident research grant stream, which has a pretty high success rate, close to 40%, which is higher than many competitions, and offers up to $30,000 for resident-led research. So keep your eye out for those opportunities. I want to extend a big thanks to PSI for sponsoring Dr. Lavis's virtual visit today. This is our first virtual PSI Grand Rounds. A big thanks to Jim King and to Heather Howley in the research office for helping to coordinate Dr. Lavis's visit today. And now I'll turn things over to Dr. Zemek to do the introduction.
So thank you, Karen, and thank you, Jason. So it is my pleasure to introduce Dr. Lavis. Dr. Lavis and I had the chance to meet, and I've heard Dr. Lavis speak as part of our common interest in the Ontario SPORE Support Unit. And so John is a professor, a full professor in the Department of Health Research Methods, and he is a Canada Research Chair in Evidence-Informed Health Systems at McMaster University. So John is an incredibly accomplished person, and it is our absolute pleasure to have him today. So John supports policymakers and stakeholders to harness research evidence, citizen values, and stakeholder insights to strengthen health and social systems in order to get the right programs, the right services, and the right products to the people who need them. He is a co-lead for the COVID-19 Evidence Network to Support Decision-Making, known as COVID-END, which is a great acronym, by the way, which works both nationally and globally, and Rapid Improvement Support Exchange, known as RISE. RISE's purpose is to support the health system transformation in Ontario. He is the director of McMaster Health Forum, as well as a co-director of the World Health Organization Collaborating Center for Evidence-Informed Policy. In addition to all these titles, he's an adjunct professor at the Africa Center of Evidence at the University of Johannesburg in South Africa. Very accomplished with his education. He has an ND from Queen's University. He has a Master's of Science from the London School of Economics and a PhD in Health Policy from Harvard University. So we are very excited to hear John today speak about creating a rapid learning pediatric health system. And again, thank you, John. I know how busy you are with COVID and all your other responsibilities. So thank you for taking the time to meet with us at CHIO today.
My pleasure. Thank you very much for having me. Roger, can you just reassure me you can see my slides on full screen?
Yeah,
Great.
it's all there.
Yes, we can.
Excellent. All right. Thank you very much. So I'm using my RISE slide deck today. If there's time, I might pop up as a COVID-END slide, and I have one on the forum. But RISE is co-led by myself at the McMaster Health Forum, Jeremy Grimshaw at the Ottawa Hospital Research Institute, and Rob Reed at Trillium Health Partners Institute for Better Health. So mostly I'm going to be speaking with my RISE hat on. So the learning objectives today are to raise your awareness about progress and challenges in creating a rapid learning system in Ontario. So the biggest government initiative, certainly of the 28 years that I've been working in the system, is underway right now with the creation of Ontario Health Teams. So I'll give you a bit of a feel for that. And this transformation is going to be really important for researchers and clinicians to understand, because it is really going to be the way that we talk about the health system moving forward, and knowing how to position your work in the context of Ontario Health Teams is going to be critical. The second thing that I want to talk about is how you can contribute with any data analytics work that you're doing, with any primary research, with any systematic reviews, with any citizen and stakeholder engagement to rapid learning and improvement. So knowing how to understand problems, frame paths for improvement, support implementation, and then drive monitoring and evaluation. And then I have a summary slide that gives you a listing of ways in if you want to be informed change agents in the health system, and do so in ways that involve you collaborating with patients, clinicians, and health system leaders to improve the quadruple aim. So I'm going to start with that first objective, progress and challenges, give you a bit of a feel for what's happening with this transformation in Ontario. So in case you don't know about Ontario Health Teams, they're a new way of organizing and delivering care that involves the full range of health providers. So home and community care, primary care, hospitals, many others, working together in one coordinated team to achieve the quadruple aim. If you're not familiar with the quadruple aim, my short form version of it, it's about improving care experiences, improving health outcomes, keeping per capita costs manageable, and keeping providers, clinicians, and others engaged in the system. As these teams develop and mature, they'll become clinically and fiscally accountable for delivering care to a defined population. With this transformation in Ontario, we refer to that as an attributed population, and I'll come back to that shortly. As of right now, they are not either clinically or fiscally accountable, but once the contracts come into place for teams, they will become the unit through which funding flows out to the constituent partners in an Ontario Health Team. I've spent many years studying health reform and health systems in this country. And to me, this change is as big as back in the 50s when we introduced universal coverage for hospital-based care, and in the 60s when we introduced physician-provided care. We'll see if it survives a change in government or a change in leader in the future, but certainly we're on a path to a very massive transformation. But to make it a landmark transformation, we have to transition from the usual pilot projects thinking that we have in Ontario to make sure that every step is a step towards full scale. So to give you a sense of Ontario Health Teams, it's important to know that they vary widely in size. So the government had not initially set a minimum number, but the number has now been set effectively at 50,000 Ontarians, up to Mississauga, which is the largest approved Ontario Health Team with 870,000 people. And Ontarians are attributed to a team based on care patterns. So it's based on where you go. So if I work in Hamilton, live in Toronto, typically see a primary care physician in Toronto, I would be attributed to my health team in Toronto. But if I see my primary care physician and receive most of my care in Hamilton, I would get attributed to the Hamilton, Ontario Health Team. These teams, because the individuals are attributed, and it's not geographic, there is no alignment with the boundaries for local government. So Hamilton Health Team does not mean Hamilton, the city of Hamilton. Had that been the case, it would make it easier to align with broader human services and public health, which sit within the city of Hamilton, but there is not that direct alignment. We've tried service integration a lot in Ontario in the past. Many of you will know HealthLinks, bundled payment, rural health hubs, but they were typically seen as pilot projects, not positioned as a once-in-a-generation system transformation. And while co-location of services, what some people call hubs, are not formally part of the OHT model. They are being used by some OHTs. And where we currently are in the approvals process is 24 teams approved back in December of 2019. 5 more came on board in July 2020. They're all considered cohort 1. And then 13 teams were approved in November 2020. At maturity, those teams, the 40 plus teams, bring us to 86% coverage of the Ontario population. So we are working behind the scenes with teams that are called teams in development to support them to either join an approved team or to come together as teams in development and submit a joint application. And when that happens, we would be at 100% of the Ontario population. So if I move a bit from progress to challenges, from our perspective, myself, Rob, Jeremy, others that are involved in RISE, the biggest challenge with this transformation is using a population health management approach, which is very new for Ontario in many regards, to move the needle on quadruple aim metrics for the entire attributed population. That's the long-term goal, but in the short run for priority populations. The bulk of the approved Ontario health teams have picked one or more of the priority populations that you'll see in that list. You'll note that pediatric populations are not singled out there, although there are some Ontario health teams that have, for example, prioritized youth with mental health problems within that second priority bundle. While Ontario health teams are transitioning to this population health management approach, they're also putting in place what we call the 8 Ontario health team building blocks. And I'll show you them in more detail on the next slide. But I'll just say that right now, as a close observer of what government and increasingly Ontario Health are doing, the pieces of the building blocks that right now are getting the most attention in Ontario are patient partnership. So a lot of patient partnership got left behind in the COVID-19 period, but there's a growing recognition of the need to get meaningful patient partnership back on track and prioritized. There's a big focus on physician leadership and engagement, in part pushed by the Ontario Medical Association, but also recognized by many people as being essential to the success of the OHT model. There's a big focus on data analytics, but as I'll come to, a real gap in our real-time data analytics platforms. And there's a big focus on collaborative governance. So unlike, let's say, Alberta, where the transformation involved getting rid of all the independent boards, in Ontario, we've retained them all. And we now have 20, 30, 40 boards coming together in a collaborative governance council, making decisions together, but retaining their independence as boards. So they are becoming jointly accountable for shared goals, but their individual boards are the mechanism through which that then gets implemented. So this transition to population health management, from our perspective, is the biggest challenge that we face in moving forward with this model. But just quickly, a bit on the building blocks. On the left side, you'll see the 8 building blocks. The ministry had somewhat different language. Initially, we've been pushing over and over again to have simple language. So this is the language that we and increasingly the ministry use to describe the building blocks. I mentioned certain ones are getting disproportionate attention right now. Those are the ones in light blue. The one that we and many others are the most obsessed with is the population health management one. So RISE, the Health System Performance Network, led by Walter Wojcik, Advance, led by Ross Baker, are among those supporting that transformation. The work on patient partnership, many people involved in this. I saw Simone, who's supporting this kind of work as well. I put up one particular group, Patient and Public Engagement Evaluation, led by Julie Abelson as a research group here. On the data analytics front, many groups, the one that you'll hear me talk about a bit later, Integrated Data Solutions or Systems, IDS, really, as far as we can tell, the only thing approximating a real-time data analytics platform that crosses the multiple OHT partners or has the potential to, but we have, of course, always the gold standard ICES, and then we have entities that use ICES data in primary care, in particular, Inspire Ph.D. and the Ontario Community Health Profiles Partnership. And then as part of building block 5, we also have digital tools, many groups supporting that work, including one based in Ottawa, the eConsult Center of Excellence. Collaborative governance and physician leadership, I mentioned Advance already, and I mentioned the OMA is particularly active on that front. So while most of what I'm going to talk about next is population health management, keep in mind that these building blocks are also being put in place simultaneously. So a little bit more about population health management. I always trip over having clinical as an adjective because clinical to me is about service individual encounters. Population health to me is thinking about populations, but this is thinking about populations, but in terms of how we deliver services to them. And so some of the hallmarks of population health management is segmenting the population into groups with shared health and social needs, using an equity lens and addressing barriers that they may face in accessing care, proactively managing chronic conditions and behavioral risks, not just responding reactively when patients walk through a clinic door or into the emergency room, making sure that interventions are individually focused and proactively applied. So while we're thinking about populations, at the end of the day, they need to be appropriate to each individual within that population segment and apply good clinical care consistently for everyone across population segments. So we typically think of the Ontario health system being focused on curve 1. It's the people coming through our doors now. Curve 2 is about all of the people who we need to reach, whether or not they are currently seeking care now. And we're trying to shift that second curve to the right. Curve 3, critically important, but not something I'm going to focus on today, but that's using more population-based strategies, housing, other actions where you target the determinants of health to try to shift the curve. But I'm going to talk about trying to better align the health system so it not just is good at reactive approaches, it's also excellent at proactive approaches and identifying people who could benefit from care and trying to bring them in to receive the benefits from the health system and ideally broader social systems. So I'm going to go through a couple of slides on population health management because it's so critical to understanding where we're heading in Ontario and where the pathways to influence are for research. So this is what's commonly thought of as the risk pyramid that's used in population segmentation. So we have lots of healthy patients. They may be very healthy or have well-controlled chronic illness. Then there's the ones with unstable chronic illness that have rising risk. Then the ones that are medically complex and high risk. I don't like the term super users, but we're using this pyramid drawn from Kaiser. That's a label that they have used. Some of the wording on the right-hand side isn't ideal for your populations, pediatric populations, but you'd be able to substitute what you consider to be appropriate terms there. So as you move up the pyramid, on the left side, health risks and medical complexity are increasing. And on the right side, the need for care management and coordination is increasing. So that's how we start to think about how we provide increasing services to meet growing health and social needs for those groups that are closer to the top of that pyramid. But we also need to be focused on prevention and support to the large group of healthy patients at the bottom. Some of the common functions that cut across segments, and again, the wording's perhaps not ideal for pediatrics, but identifying and managing social needs would be familiar to you. Care integration, perhaps for on the mental health side and with some of your teens for substance use issues, and then team-based primary care and self-management support would of course be critical as well. So now if we look at it not from those common functions, but coming at it from health programs and interventions targeting different levels of the risk pyramid, at the base, engagement, screening, counseling, navigation, moving up a level, chronic illness care, collaborative care programs, care coordination, Moving up again, higher risk care management, and at the very top, high risk care management, and for some palliative care programs. So if you now look at the data sources, so for those of you who do a lot of work involving data analytics, if I start at maybe 1 o'clock think of this as a clock, administrative data and scoring algorithms like CIHI's health profile groups, registries and intake data, EMRs like Epic, community and contextual data, QI and research studies, and patient-generated data are all examples of the data sources that can inform step 1 in population health management, segmenting populations and understanding barriers to care. Now, if we talk about, well, how do we use the data? And here I'm using the example of an EMR, so Epic, but one of the challenges that we face with EMRs is they have data on the patients that have come through your doors, but not on all of the potential patients that you need to be paying attention to. There is the potential to take a data analytics system like IDS and pop those data into an EMR like Epic. Epic has in fact been designed to support population health management, incredibly powerful tool. But in Ontario, our big challenge is making sure it has data on all Ontarians and not just the patients who are actively receiving services from us. If I again use a clock face analogy and start at the top and go around, these data can be used to track patient enrollments, to identify patients with specific diseases or problems, to document demographic and social factors, track health outcomes, track functional health status, identify missed opportunities and follow-ups, track care gaps, hospitalizations, and ER visits. And if you're able to add non-medical care data to the EMR, and you can start to get at hostel stays, using community-based services, all of those additional types of data, then you'll be in an even more powerful position to identify gaps and address barriers to care. So now if I move on to step 2, this is the only other step that I'm going to go into any detail. I think I just have 2 slides on this one. This is about co-designing care pathways and service mix. So having segmented the population into groups with shared health and social needs, the next big challenge is how do we identify appropriate care pathways and service mixes for each of those unique population segments. So we have found it most helpful to think about an expanded chronic care model for population health. Here I'm focusing on that health system bubble. So we recognize with curve 3 that healthy public policy and other things over in the yellow community bubble are key. But here we're saying, how can we make changes to the health system that will optimize the care and make it more proactively delivered to meet the health and social needs of everyone in the population, not just the ones who walk through the door. So that means thinking about system design, information systems, decision support, self-management support. And if all of that is working well, hopefully we have an informed, activated patient and a prepared and proactive care team that are working in partnership to make the best decisions for each individual. So delivery system design, OHTs are creating new roles, using new tools. I don't think I've used the terms yet, in-reach and outreach functionalities. In-reach means someone may have come into your door or into your clinic because of problem X and received service Y, but you take advantage of their presence to proactively offer other services that they may benefit from. Outreach is reaching out to people who should be coming into your door and trying to bring them into the system because there may be health and social needs that they have that are not currently being met. And population health management is as much about bringing those people in as it is proactively reaching out to those who are already within the system. Delivery system design also includes care coordination, care management, and addressing barriers to care. Clinical information systems, I've talked a lot about that already, registries, trackers, and so on. Clinical decision support, again, I've alluded to the clinical pathways, guidelines, but Epic is hugely powerful for things like prompts and reminders when done well, and patient self-management. These are the interventions to build motivation, skills, and capabilities for behavior change. So this is a pretty new world, you know, for organizations, hospitals, primary care clinics, community-based services, and so on, to be working collaboratively to engineer a delivery system redesign to far more effectively harness our information systems, to work together to have decision supports that address all health and social needs, and to try to support patients in making decisions that are right for them. I'm doing all of this in a way that is much more proactive than we've ever done before, and certainly much more coordinated than we've ever done it before. So the final slide is what's not yet clear is how provincial and regional specialized services, like many of the ones that CHIO provides, will intersect with population health management specifically, or with OHTs in general. So if I was at CHIO, one of the things that I would be thinking about is how can we be thought leaders in shaping thinking about specialty contributions to a rapid learning pediatric health system. So CHIO's catchment area is going to cover many Ontario health teams. How is it going to think about its role going forward in supporting population health management? Clearly, a lot of what you do is at the top of that population risk pyramid, but there are many opportunities for CHIO, I think, to be actively involved in population health management, and I'll come back to some of those potential roles later on. So the next objective is to talk a bit more about how any data analytics work you're doing, any primary research, any systematic reviews, any citizen and stakeholder engagement can support rapid learning and improvement. And I'm going to come at this through three different angles. The first angle is I'm going to talk about what we're doing with RISE, because there are opportunities for folks at CHIO and in Ottawa more generally to contribute through RISE, but then there are other ways that you can contribute more generally. So RISE is part of the ministry's OHT Central Program of Supports. There are other groups involved, like Advance with Ross Baker, Patient and Public Engagement Evaluation with Julia Abelson, the Health System Performance Research Network with Walter Wochus, others that are part of that central program. We modeled our particular approach on the technical support groups that supported the introduction of ACOs, Accountable Care Organizations in the US, groups like Mathematica, that provided evidence-based support to the introduction of ACOs. So it's been hugely helpful for us because OHTs share many characteristics with ACOs, and a lot of lessons had been learned about the nature of the evidence-based technical supports that ACOs needed. So our vision is a rapid learning health system that continuously ups its game in achieving the quadruple aim. Our goal is to provide timely and responsive access to Ontario-based rapid learning and improvement assets. And we are very actively seeking out the best of the best across the province. What we do not want is the usual reliance on downtown Toronto-based groups. We want to know who is doing the best work in the province of Ontario on given areas that OHTs need to be dealing with, and then we want to connect them to ensure that everybody is playing to their comparative advantages and we're benefiting from all of the resources across the province. Our program objectives, these are the ones that speak to OHTs. We have others related to COVID-19, but support rapid learning and improvement. And on the next slide, I'll talk a bit about our coaching, collaboratives, and communities of practice. We do a lot of on-demand activity and product-related work. So we'll do rapid syntheses, for examples, on topics. In an hour, I think I'm hosting a jamboree, bringing together all the key players that are involved in supporting this transition to population health management to try to get everybody on the same page. and we share tools and resources. So if you haven't seen our website, we try to provide in one place everything that can support Ontario health teams, regardless of who in the province produced it. And we have a number of webinars, and you can sign up for a monthly newsletter. But the pieces that we're most focused on right now are the very hands-on coaching and the collaboratives for population health management. So again, we've borrowed this from the US experience, showing that this is such a dramatic change for our health system to move from that curve one focus to doing curve one and curve two, that teams need very hands-on support. They need hands-on support from coaches that come in from the outside, and they need support to connect with one another to learn about how they can do things better or differently. So we have now one coach in place for every 5 to 6 approved cohort 1 Ontario health teams. They are going to be working with the lead for population health management in every team. Often that person is the executive lead for the Ontario health team, but also the clinical and operational leads for the priority population working groups. So if it's a working group focused on improving care for people with mental health and addictions, it might be co-led by a psychiatrist and a senior VP in charge of service delivery. So those are the targets of the coaching. And the coaches act as facilitator, as a mentor, and very directly as a coach. So this is turning all of these resources available to teams into very practical, this is what it means for you in your journey towards moving from curve one focus to curve one and two. The collaboratives are time limited, goal directed, supported by the coaches as well, and they're an opportunity for groups that working with the same priority populations to come together, to hear new ideas, to share with one another what they're doing, to have an open conversation about how to do better, and very importantly, they have to commit to action and put in place between meeting action plans. So these collaboratives based largely on IHI type approaches, Institute for Healthcare Improvement. We also have more open-ended and member-driven communities of practice focused more on the building blocks. The 3 active ones are focused on patient partnership, digital health, and performance measurement and improvement. So these are open, so you can go online and join one of these communities of practice if you're interested in supporting OHTs in any of those areas. So now if I come at rapid learning from a different lens, less how we're approaching it at RISE, although I'll speak a bit to RISE, and more the 7 characteristics of a rapid learning health system. So we did a lot of work looking at rapid learning health systems around the globe and distilled down 7 characteristics that for us were emblematic of a rapid learning health system. So 4 of them are on this slide, 3 are on the next. On this slide, you see engaged patients, digital capture, linkage, and timely sharing of data, timely production of research evidence, and appropriate decision supports. And in blue, you'll see the opportunities for data analysts and researchers and systematic reviewers and evaluators to help with these characteristics. So if you are an evaluator focused on patient, family, and caregiver engagement, that is hugely helpful for the engaged patients characteristic. If you are a data analyst and have incredibly great data analytics and modeling expertise, you can help with characteristic 2. If you are a researcher doing primary studies or doing evidence syntheses or developmental and summative evaluations, you can help with characteristic 3. And most researchers will find themselves in that row. Some of you, though, maybe working with guidelines. Ottawa is one of the world leaders in patient decision aids. So that's currently a gap in the OHT model in terms of that being a clearly defined set of supports for teams. And if you're working with EPIC and thinking about how to enrich EPIC data with outside data about the patients that you could be seeing but may not currently be being seen, then you would fit into that 4th characteristic. The final three characteristics, two of them are less amenable to researchers, data analysts, and others, but they are aligned governance and financial and delivery arrangements. So those kind of bigger picture architecture pieces of the health system. The culture of rapid learning and improvement, but for the competencies for rapid learning and improvement, for those of you who know how to do logic models, are skilled at monitoring and evaluation, huge opportunities for you in the months and years ahead to support rapid learning and improvement with Ontario health teams, because they will often find solutions, what works for the kind of Highway 60 future OHT with Renfrew and others might look very different from the one that gets set up in Mississauga. And learning about what works best in different contexts and for whom is going to be a big part of how these OHTs achieve their successes. The third and final lens on how your research can feed into a rapid learning system is to think about the 6 steps in rapid learning and improvement. So when we talk with OHTs about trying new things, like starting to segment populations as part of a movement towards using a population management approach, we often say, think about being clear about the problem or the goal, co-design the way forward, be very systematic in implementation, always be monitoring and evaluating, adjust as you learn, and then make sure that once you've figured out what is getting traction, then how do you move that to coverage of that effective solution across the entire, in this case, local health system that the OHT is responsible for. But you'll see things like CHIO's EPIC, primary research, synthesized research evidence, citizen and stakeholder engagement, fitting into particular pieces. So if you're trying to make a difference and support rapid learning and improvement, it's really critical to understand where your type of contribution as a data analyst, as a primary researcher, as a systematic reviewer, something else, how you fit into the rapid learning and improvement cycle. So the final objective, and rest assured I'm almost done this, I only have one slide on this, it's to get you thinking about how you can act as informed change agents who can make a difference in our health system. So I've put here some options for you to think about. And as I said at the beginning, if you want to make a difference in Ontario's health system, it's really important that you understand the language of Ontario health teams, the language of population health management, the language of the OHT building blocks, because for your research or data to land and to make a difference, it has to be understandable to people in this new way of thinking about how Ontario health teams are going to be making a difference on quadruple aim metrics. So some ways in for you. You could work with your local OHTs. Ottawa has several in its area to use a population health management approach. You could work with the collaboratives and through the collaboratives with the coaches to use the population health management with priority populations across OHTs. The challenge for CHIO researchers in the short run, as I mentioned before, is really none of the OHTs, or certainly not a significant number of them, have prioritized pediatric populations. So you'll sometimes, as I said before, see youth in, for example, with mental health. But these priority populations are just the initial focus to help teams get their feet wet. They will need to move quite rapidly to doing the same thing for their entire attributed population. And then, of course, kids are going to be front and center in that mix. Another set of ways in are to think about how you can contribute to any of the 8 OHT building blocks. But I'll tell you right now that the big focus is 3 of those building blocks. Patient partnership, if you're working in that space, big new push on that with OHTs. Second one is data analytics and digital tools. Big focus on data analytics. Our big problem is currently the lack of a real-time data analytics platform like IDS at scale, but there's huge opportunities there. And the other opportunity is if you're working in the space of collaborative governance or physician leadership and engagement. Another way in is through those characteristics of rapid learning health systems. Slightly different way of thinking about it. If you're working with engaged patients, if you're working with data, if you're trying to, in a very timely way, produce and share research evidence, or if you're working in decision supports, huge opportunities for you on that front. And the final way in is to think about how your research can inform rapid learning and improvement cycles. You may be doing research that helps you understand a problem. You may be doing research that helps in the co-design of solutions, or you may be doing research related to monitoring and evaluation. All of those are ways in. So I'd strongly encourage you, if you want to be part of this massive transformation and see your research applied in real life to make a difference with health outcomes, care experiences, keeping costs manageable, and keeping providers engaged, then think about learning this language. Think about how your data and research feeds into these different ways of thinking, and that's likely going to be how you're going to have the maximum impact. So if you want more information about RISE, you'll find it on our website. If population health management is new to you, you'll find some webinars and a RISE brief on the topic. If you want to know more about these OHT building blocks, you'll again find a RISE brief on it. There are rapid syntheses that may be particularly relevant to you that you might want to look at. All of that is on the RISE website. As I mentioned before, I have a slide if we have time for later about COVID end, so we'll see how it goes. But if I go back to our objectives, which were right here, most of what 99% of what I wanted to say is covered through this kind of RISE lens. So I think I'll end it there. It's a tremendously exciting time in Ontario, although, you know, with COVID, obviously, that has taken away a lot of attention from this, but a lot of Ontario health teams are using a lot of this thinking to address COVID. But as COVID comes more under control, the renewed focus is going to be very much on Ontario health teams. And there is exciting kind of thought leadership that can be provided from entities like CHIO that have more of a regional or provincial lens that need to think about intersections that haven't yet been fully thought through. So happy to take any questions or comments. And then, as I said before, I can come back to one or two final slides if there's time.
Thank you very much, John. That was really an excellent presentation. Really covered a lot of ground. For those asking questions, can I just encourage you to put your hand up, and I'll take them from there. It'll be easier. So, Mary. Thanks so much. Can you hear me? Yep. Yes, I can.
Excellent. Thank you so very much for this presentation. OHTs are a fascinating progression and appreciate this work is happening. CHIO and 62 partners actually submitted an OHT application and was approved in the first round, but under the innovative model, not the traditional geographic population model that you've been focusing on in this presentation. So responsibility for children and youth in quite a broad geographic area with a focus on mental health and medical complexity. So I am curious if RISE is exploring how the innovative models, and I think there's a few of them, so CHIO's being pediatric, I think there's another more provincial view as it relates to mental health and addiction, whether those innovative models have a role to play within the framework you've been talking about today.
Yeah, so, you know, to me, it brings us back to that point that I raised about the specialized line of thinking. So I didn't use the innovative models language because the ministry has not been talking that way for a fairly long time. So I think originally they thought that might be a path that they wanted to pursue. I don't think that they've ruled out the possibility, but I think they realize that they have bitten off an unbelievably big transformation, and then to have COVID overlaid just meant that they're sticking with their knitting. But the innovative models, and I'm aware of yours, and I'm aware of the one that was led by folks in Penetang and other places on mental health, that thinking still needs to be done. It's just that it hasn't bubbled up to the top of the priority list. The question that is, front and center on this in my mind is, who is going to shape that thinking? Is it going to be the ministry as we originally understood it? Or as Ontario Health starts to come out from this very big focus on COVID, are they going to, as they take over responsibility for Ontario Health teams, going to be the ones that think about that intersection with provincial and regional specialized service delivery lines? So I think, as I said before, there's still lots of thought leadership, and kudos to you and others who would have been involved in this one on pediatrics. These problems or opportunities still need to be addressed, and I think the time will come. We're not there yet, but I think it will come. We're not active in the area because we have our hands full with all of what we're already doing, but we're really excited about thought leadership that could come forward in this space. Does that answer your question?
Yeah, that's really helpful. I would say that Kids Come First has had a huge impact through the pandemic because it built some relationships that were really needed. But to your point, we're struggling to get it noticed or embedded in the broader system. Thanks for that.
No problem.
Bill, I see you there. Welcome. Good to see you, and give you an opportunity to ask your question.
Thank you, Karen, and thank you, Professor Lavis. I'm going to just push you on one point here, big point though, I hope. A lot of the overall vision that you've put out here of a healthcare system that is very highly data-driven and does a great job of tailoring services to the needs of the individual and tracking them over the time and making sure that there's a well-coordinated core of services they're receiving is and is constantly improving through a learning health system is something I really felt like was central to my career goals. And in the last year, though, I got sick myself, and that led me to question this in a big way. And I'm not advocating this position, but I'm going to be a devil's advocate here and say what I've experienced in trying to get care for myself is that the healthcare system is hundreds of kilometers away from what you're talking about here. That I was in trying to get cancer care, I had great difficulty of getting any kind of response when I reached out for help with various things. I also found that both my primary care doctor and my oncologist could write orders all the time and get no response from the diagnostic imaging. And I kind of thought, the system we have is just so far from being fit for purpose for the very highly tailored, planful thing that you're talking about, that I wonder how it will ever work in a finite amount of time. What that leads me to believe, not to believe, but to question, is if we have a marginal dollar to spend on all this and a marginal hour of work, maybe it's better not just to try to make the healthcare system yet more elaborate, but actually do the primary population health things that we've neglected to make sure that Indigenous communities have clean water, that everyone has access to adequate housing, the kind of classical population health stuff, which, it's dumb, but it possibly could work better. And I'm just wondering how you see the balance between those two different approaches to improving population health.
Yep, absolutely. Thanks, Bill. And sorry to hear about the brutal experiences. What you're essentially saying is, if I go back to my curves, we've been at curve 1, and we sometimes do curve 1 okay, other times not. In your case, it sounds like not. This is a transformation to add curve 2 to that mix. And you're saying, should we actually be leapfrogging over 2 to curve 3 with the population-based strategies like housing, safe water, and so on? And my hope for the system is surely we can walk and chew gum eventually and be doing all 3 of them. So we are reacting. Curve 1, we can do it better. We have to start doing things in a more coordinated and planned way, curve 2. And then we have to be addressing the housing, water, and other things at the same time. So this presentation has been primarily about adding curve 2 to curve 1, but I feel like we have to have curve 3. Do I think we're going to get there? Well, in any kind of a timely fashion. Well, if anything's going to do it, it's going to be the move to a single integrated funding envelope and the holding people accountable to quadruple aim metrics. So shitty care experiences like you have, shitty provider experiences like people sometimes have with the interplay with diagnostic imaging, others, those are going to be the metrics that the local systems end up getting held accountable for. So the hope is that the funding aligned with those metrics is going to be enough to get people to really take seriously this transformation. Will we do it? I don't know, but it's the biggest opportunity that I have seen in the 27 years that I've been studying the system to actually engineer it in ways that will really make a difference on those quadruple aim metrics. So I am optimistic about it, but it's going to need a lot of heavy lifting from a very large number of people in order to realize these goals that have been articulated. So I think being a devil's advocate is a really good thing, because this is aspirational, and if people don't pick at it and ask very tough questions, we might not get there.
John, I'm just going to pick up on a question from the chat. Does OHT RISE suggest any methodology for implementation of guidelines or suggestions that OHT building blocks will develop? And how will you measure the success of implementation?
Yeah, so not per se. I mean, the interesting thing has been, you can tell from the co-leadership model, like I come at it, and the Health Forum comes at it more from the bigger picture policy system lens. Rob Reed and his colleagues at the Institute for Better Health come at it more from the organizational lens. And then Jeremy comes at it more from the kind of provider behavior change side. And the interesting thing that we have observed among the 3 of us is the appetite has shifted from primarily stuff that we tend to do to stuff that Rob tends to do, but we haven't yet got to the on the ground implementation stuff where Jeremy and other leaders in Ottawa will be front and center. So we have not, the short answer is we have not got there. We recognize it's important, but these higher level issues have been prioritized by government. So that has drawn our attention. And then once we get further down the path, we hope there will be much more active engagement on the guidelines and guideline implementation front.
Great, thank you. Natalie.
Hi, thank you for this great presentation, something very, very dear to my heart, I have to say. So I work with children with medical complexity, and back in 2010, or between 2010 and 2011, as a partnership with our community here, we applied to the Health Link, which was the Ontario funding envelope, I think equivalent to the OHT, or modified, a modification of the OHT. At the time, this was not taken on by Ontario because the focus was primarily pediatric, and they wanted to be population health. Having said that, a lot of the issues in pediatric are somewhat different than adult population. So basically what ended up happening is this was put in the hands of the PCMCH. And through the PCMCH and other complex care program and so on, there was an initiation of the CCKO Complex Care Kids Ontario, which is really much what you are describing as an intervention and addressing the healthcare issue in partnership with families, community, everyone involved, but in sort of at the peak of the population. I guess one of my question is, how does OHC, or how would you recommend such an intervention that's happening at a pediatric level, that's already implemented, that is evolving, and to make sure that we're aligning this work along the OHT and continuing to expand this? Because in my mind, we are already doing that kind of intervention and work, but there might be opportunities to improve in that overall approach. Is there an opportunity even for PCMCH to engage more in an OHT that's more population-based, pediatric, and aligning with the CCKO?
Yeah, great. So, you know, the short answer would be that the best thing I think you could do would be write a brief about how all of this thinking can work for a pediatric population. And if you want examples of this, we've written RISE briefs for those 4 priority populations that I mentioned before. So you could use those as a model and say, here's everything that you would want for a population health management approach for pediatric populations. Here's what the programs look for higher up in the risk pyramid and so on. So that would be the best way to get it in one place using OHT language. And then we can post it on the RISE website, bring it to people's attention, because as I mentioned before, OHTs, most of them have picked from this list of 4 priority populations as of now, but they all need to move to all other populations in the coming years. So if there is well thought out population health management based approaches for kids that are already described using OHT language, then as OHTs start to think about new populations, then the hope would be that they would bring that in and act on that work. So that would be the most tangible thing to do. So if you go to the RISE website, you'll see the RISE briefs, 1 for each priority population. If you're able to produce something that looks like that for a pediatric, complex pediatric population, that would be fantastic. Does that make sense, Nathalie? Yep, great.
Yes, thank you.
Michele?
Thank you very much. It was a really interesting presentation, and to be frank, I didn't know a lot of what was going on, so it was very helpful. My question is really about EDI and how EDI is being considered through this process, everything from, you know, future healthcare delivery to data analysis and metrics, but also in the, I'd be interested to know how it's been considered even in the leadership teams that are doing this planning and building the systems.
Yeah, great question, Michele. Again, the short answer is, I think the self-assessment from most of us involved in OHTs has been, we've done a terrible job on this, but COVID-19 has really made people laser focused on EDI considerations, and the current draft of the TPA or the performance requirements for OHTs approved as part of cohort 1 and 2 make explicit the need to have EDI considerations run through patient partnership, community engagement, co-design, other things. So my sense is the tide has shifted in a fairly dramatic way to give greater attention to EDI considerations. In round 1, only 2 populations were focused on, Francophones and Indigenous peoples, but now there is a cross-cutting focus on EDI. So it's just beginning. It's just in the most recent documents and the draft documents over the last couple of months that we've seen it appear, but my sense is it's going to be front and center in a very dramatic way going forward. Make sense?
Yes, thank you. It being considered as well in terms of the teams who are doing this.
Absolutely. And yeah, because I think that, you know, if you were to look at many of the patient partners, many of the leadership tables, it's primarily, older, affluent, white, some often men, sometimes women. It's really not reflective of the diversity of the communities that are being served. And so the most recent documents coming out from government are really giving much greater attention to making sure that all aspects of OHTs are reflective of the communities that are involved. But as you probably know, it's a big challenge that will be ahead, but at least the right signals and the right performance standards are being established in things like transfer payment agreements to drive attention to this as something that people need to be accountable for.
Great, thanks very much.
So we are at the end of our time, and I would just like to thank John for his excellent presentation, for really informing us a great deal about this whole process, and really look forward to how pediatrics is going to be better integrated within the structure as we go forward, because I think there's clearly a lot of work that needs to be done in that area. So we'll draw it to a close. Thank you so much, and bid you all a good day.